We do get started today, even though she's not here. I wanted to recognize Dr. Lai. She has done an outstanding job with Grand Rounds this year, and she has really brought in some quality speakers, and today is no exception. And so in her absence, I have the honor of introducing Dr. Jay Wish. Dr. Wish attended Tufts University Medical School, was a clinical and research fellow in nephrology at Tufts New England Medical Center, and currently he is a professor of medicine at Case Western. He serves there as the medical director of dialysis and also medical director of medical quality. He is a member of AOA, and I think for at least 6 years has been recognized as one of the best doctors in America. He is the vice chairman for the editorial board, I think, for Nephrology News and Issues. Also serves on the editorial board for C. Jason, a reviewer for Kidney International, New England Journal of Medicine, and Jason, I believe. So today he is going to speak to us about the bundling and the quality incentive program, what it's meant to nephrology, and maybe what we can expect in the future. And since it is being recorded, we will ask that you hold your questions, if possible, to the end of the presentation. Welcome to Greenville, and thank you for coming.
Well, thank you very much. It's a pleasure to be here. I'm more used to doing kind of interactive stuff because I think it keeps people awake, but I guess we'll keep it didactic for the purposes of the recording. I just want to remind everybody that even though I'm going to be talking about bundling, which of course is a CMS initiative, I am not an agent of CMS. I'm just a messenger. Okay, so don't blame me if there's anything that I tell you that you don't like. What I'm going to try to do is give you some background about bundling, how this came to be, what were the political and economic realities that were being addressed in the whole bundling program, and then, as the title says, 1 year later, bundling, as you know, went into effect January 1, 2011. It's not quite a year, but we do have some information in terms of what the consequences of bundling have been, some expected, some perhaps not quite so expected, and we'll talk a little bit about that and then talk about what the CMS plans are for the future in 2013 and 2014. So for those of you who remember before bundling, why is it that we are in the bundling environment now? It's all about EPO, okay? To be perfectly blunt, bundling is about EPO. And this goes back to 2006, actually, when the Choir and the Crate studies were published. Actually, they came out while we were at ASN in San Diego, for those of you who remember, which basically showed not only weren't high hemoglobins better for patients, they were actually worse. And this got the attention of Congress, and Congress noticed that the mean hemoglobin among dialysis patients in the United States was 12, and here we had a couple studies that showed that hemoglobins were 13 were killing people, and they said, oh my God, we have a perverse system here where dialysis units are being encouraged to give more EPO, because the more EPO they give, the more money they get, and therefore we got to do something. More EPO from being a profit center to being a cost center. And by bundling it into the composite rate, along with other things like vitamin D, etc., they felt that this would change the whole culture of how dialysis units are run and discourage excessive EPO use, and we basically make patients safer. And the major political agenda actually was patient safety, and the fact that the encouragement of high EPO use under a fee-for-service environment was actually putting patients at risk. At the same time, they also noticed the cost of ESAs in the ESRD program were at $2 billion, that's $8 billion per year. So you can think of that as $2 billion a year going directly from Baltimore, Maryland, where CMS is, to Thousand Oaks, California, which is where Amgen is. Amgen was the only people that made EPO. And as I mentioned, 50% of patients had hemoglobins greater than 12, and basically they felt this was necessary to protect patients. So under the old rule, 60% of what CMS paid to dialysis providers was for the dialysis treatment itself and the included labs. And in 2008, which is what these figures are from, actually 2005, that was a little under $5 billion a year for the dialysis composite rate itself. And then 40% of what CMS paid to dialysis center was for these separately billable items, of which 2.7 billion was parenteral drugs, and of which 2 billion was the ESA. So you can see, if you add up all the figures, ESAs were close to 20% of the total ESRD budget. Now, we're not talking about hospitalizations and stuff. We're basically talking about the ESRD budget for dialysis and associated costs. But, that's a fairly big ticket item. So basically, Congress called upon CMS through the MIPA, the Medicare Improvement for Patients and Providers Act, that was legislated, I believe, in 2008, to change the methodology of payment, to bundle ESAs and the other stuff, to encourage facilities to curtail ESA use, and in so doing, decrease hemoglobin levels and put patients at less risk. So the major provisions of the final rule, which came out in 2010, was that the base payment rate would be around $230. Now, the previous dialysis composite rate, which dialysis facilities collected per treatment, was about $130, and then they ended up billing for miscellaneous stuff that added about another $100 per treatment. So this was supposed to be all pretty much neutral. Actually, it wasn't quite neutral because the MIP also said that we're going to cut 2% from the entire dialysis program. So after they figured in how much they were going to cut based on the MIPA requirements, they came up with a base payment rate of about $230. Now this excludes all the adjustments, almost all of which are positive. So this is probably the least you're going to get for the least complicated patient. And as we'll show you, there are both facility level adjusters and patient level adjusters that will allow you to collect more per patient if you're a small facility, if the patient's particularly complicated, etc. It's a per treatment unit of patient, or payment. And this is up to 3 treatments per week unless medically justified. And as you know, you can apply to your local Medicare carrier for payment for a 4th treatment per week if the patient has a medical indication. And by and large, most of the carriers are approving it. So for instance, most patients are on home dialysis, get a 4th treatment per week paid for. But the concern was that this may discourage the use of more frequent home hemodialysis modalities because next stage, for instance, requires 6 treatments per week. So getting next stage to be even a break-even proposition under only 4 treatment per week limit can sometimes be a challenge unless you have commercial payers who aren't constrained by these rules. Now the other major issue is that the beneficiary coinsurance amount is 20% of the total ESRD prospective payment after all adjustments. So under the old system where there really wasn't much in the way of case mix adjustments, the 20% copay was pretty much the same for everybody because there really wasn't a lot of adjusters. Everybody pretty much got paid, $130 per treatment, and the patient or the coinsurance or Medicaid or whatever paid 20% of that, and Medicare paid 80% of that, and that 20% wasn't a particularly large burden. Suppose you have a patient who has a lot of adjusters, and instead of getting $230 per treatment, they get $400 per treatment. Then the copay is 20% of that. It's going to be almost $100 per treatment. So for patients who have perhaps inadequate coinsurance, this is going to be a much larger burden on the individual patient if they happen to be a high expense patient. Patient level adjusters we will go into in a minute. The facility level adjusters in this final rule are low volume facilities. So Medicare figures if you are very low volume, you lose economies of scale, the cost for treatments are going to be higher because you don't have purchasing power, etc. And therefore we're going to give you a little break. And that's defined as less than 4,000 adult treatments per year, which when you do the math comes out to about 27 patients. So if you've got a facility that's averaging less than 27 patients, then you may qualify, but it has to be less than 4,000 treatments 3 years in a row with no change in ownership. Okay? So this is to discourage the large chains from buying up the little guys just to make more money. Okay? There's also a geographic wage index. So this can be an issue if you happen to be in a low wage area. Under the old rule, before 2011, if you were in a low wage area, the most the geographic wage index could ding you was 10%. The floor was a 90% adjuster. Okay, now the geographic floor can be anything that it is. Okay, so if you happen to be in a depressed area, like I always pick Youngstown, Ohio, as a depressed area where geographic wage index is low because of the high unemployment rate, and there the index may be 60% of the national average, then that 60% is going to be applied to the labor part of the composite rate or the total payment rate and reduce it by as much as $50. Okay. The inclusion of all the ESRD related drugs, this includes the separately billable IV drugs and their oral equivalents. So if somebody comes up with a PO EPO, then that's going to be included. It's not necessarily the IV EPO that was the one in mind when they made this legislation, but in more concrete terms, it includes PO by VM. So you can't get around this rule by giving the patient an oral form of Exemplar or Hexalol and say, aha, it's an oral drug, it's not an IV drug. We'll give the patient a script, they're going to go to the drugstore and pay for it themselves. That has to be included. Includes all antibiotics administered on dialysis or ESRD related indication. Okay. And this is an important distinction. Okay, so if you've got a patient who's got a diabetic foot ulcer that you're treating because it's infected, that's not an ESRD-related indication, that is still separately billable. There was a lot of misconception on the part of many providers that all antibiotics administered in a dialysis unit under bundling would be included in the bundle. That is not true. You can actually put what's called a Y modifier on your charge and specify what the non-ESRD related indication is, and your intermediary will pay. It also excludes all vaccines. Obviously, you don't want to be financially disincentive on vaccines, which is good. Okay. There is a 2% withhold for payment for performance, or the quality incentive payment, or the QIP, which we'll talk about in a little more detail. And you can earn all or part of this back on your total performance score. And as you're probably all aware, the performance measures for 2012, which is 2 months away, are going to include hemoglobin and URR, and there will be new ones to be added in 2014, and we'll talk about those towards the end of the presentation. And all ESRD-related lab tests are included in the bundle payment, whether or not they are drawn in the dialysis facility. So you cannot get around the bundle by sending the patient to an independent lab to get their monthly iron and PTH and phosphorus and calcium and expect that they're going to bill that lab to Medicare and Medicare is going to pay for it. Medicare knows who's an ESRD patient, and if an ESRD-related lab comes to their intermediary, they're going to say, we're not going to pay for it, it's included in the bundle, have your lab bill it back to the dialysis. Okay, these are the case mix adjusters. Lower that thing too well, but anyway, I'll translate it for you. It doesn't look like the slide that I thought I had, but anyway. There are basically two kinds of case mix adjusters. There's the ones that are based on the patient's demographics, if you will, and these are actually old case mix adjusters. These were actually applied for the old composite rate even before bundling. And they're basically two characteristics. There's the age of the patient and the size of the patient. So as you will notice, there is no adjustment if the patient is 60 to 69 years old. That's considered to be the cheapest dialysis patient to take care of. If the patient gets progressively younger from 60, they get more expensive and you get more money. And as they get older from 70, they get more expensive and you get more money. Okay. Very big people, BSAs over 1.87 meters squared, pay you more money because they consume more resources. They need larger membranes, they have longer times, they consume more dialysate. There may be more labor to get them in and out of their station, etc. So they will give you another 2% payment for every 0.1 meters squared over 1.87. Okay? And then finally, very skinny, emaciated, sickly patients also pay you more. BMI less than 18.5 gives you another 2.5% payment. These are the new case mix adjusters, and these were very controversial. And for those of you who have been following this whole bundling story, there was a proposed rule that came out in 2009, and then the final rule that came out in 2010. The proposed rule in 2009 had 14 case mix adjusters that were based on comorbidities. And everybody said, nah, that's way too complicated. Let's just have fewer case mix adjusters. So Medicare finally settled on 6 disease-related case mix adjusters, okay? And they are 3 acute ones and 3 chronic ones, okay? The acute ones are recent pericarditis, recent bacterial pneumonia, and recent GI bleed. And the chronic ones are hereditary anemia, myelodysplastic syndrome, and monoclonal gammopathy. The theme that these all have is that these are conditions that probably will cause the patient to require more EPO. They're either inflamed, or they're bleeding, or they got something wrong with their bone marrow. But in any of those cases, they're probably going to require more EPO, and Medicare is giving you a larger allowance in your bundle payment to pay for that extra EPO. The onset of dialysis is in less than 4 months. So the first 120 days of dialysis, you will get 50% higher payment. This is the big adjuster, 1.5. Okay, so when we said the base payment is $230, okay, if you've got a patient that's in the first 4 months of dialysis, you get another half of that for each treatment. So instead of the $230, it's going to be close to $350. Okay. Now, Medicare, what you can't see here because it's superimposed, will allow you to pick one from this column. Okay, you can't have more than one. Okay, so it's like a Chinese restaurant, one column A, one column B. Okay, so this is obviously the biggie. So if the patient's in the first 4 months of dialysis, you will pick this one. Actually, Medicare will pick it for you. Okay, on your charge ticket, you put any of these that apply, and Medicare will automatically give you the one with the highest adjuster. So you don't have to memorize all these adjusters and pick the one that gives you the biggest multiplier. Medicare will do that for you. But of course, in the first 4 months of dialysis, this is the biggie. Okay. The facility level adjusters, as I said, include the wage index, and that applies to 41% of the payment. So again, if the typical payment is $230, 40% of that payment is $100. A 0.6 multiplier, because you're in a low wage area, because you're in Youngstown, Ohio, will cost you $40 per treatment. So the wage floor, which was 90%, is now 60%. Okay, and then there's the low volume adjustment, which we already mentioned. All right, self-dialysis training. Now, I'm not particularly enamored with this rule because of this. Oops. Okay. Facilities cannot receive the self-training adjustment and the 4-month dialysis onset of dialysis payment for the same patient for the same session. What does that mean? It means when you're training the patient, you can add another $34 per treatment for all the nursing labor that goes into the training process. Okay, also adjusted by geographic wage index. But if you want to collect the most reimbursement, you'd be crazy, in my opinion, to do your self-training during the first 4 months. Because the first 4 months, you're definitely going to opt for that 50% bonus. Remember, 50% of $230 is another $115. You can either have that, or you can have, $34. Okay, what are you going to take? $115 or $34? Okay, so what are you going to do? You're going to postpone your self-dialysis training until that bonus is over after the first 4 months. Now, I don't know if your dialysis patients are like my dialysis patients, but inertia is their middle name, okay? And if you put them in a comfortable dialysis unit for 4 months and they get used to the routine and they make all these friends among the other patients and they get used to being waited on, getting them to change that whole culture after 4 months is probably not going to be as easy as it might have been if you started the home training on day 1. So I happen to think this was a bad idea, but that's the way we did it. Okay, the outlier policy. The outlier policy is like Lloyd's of London insurance, okay? This is a pool of funds that's basically a tax on every single dialysis treatment that is put into a bank, if you will, upon which you can draw if you've got really, really, really expensive patients. And when I say really, really expensive patients, I mean really, really expensive patients, okay? So this is limited to the items previously separately billable under Medicare Part B. So we're talking about drugs and labs, all right? So if you've got a patient who's requiring tons of EPO. Now remember, under the old fee-for-service, you could bill for 400,000 units of EPO a month, and Medicare would pay for it. That's 30,000 units per treatment. That's a lot of EPO, okay? Now suppose you decide that this patient who was on 30,000 units of EPO before bundling still needs their 30,000 units of EPO, okay? That's $300 worth of EPO per treatment. Okay, now you used to get paid for that. You're not going to get paid for that anymore because it's in the bundle. So you say, well, this is an outlier. I really, really think deep down in my heart that this patient really needs those $300 worth of EPO every single treatment. Therefore, I'm going to apply to this insurance plan to get some of that money back. So basically, you say, okay, I'm spending $300 on EPO, all right? There is a deductible on this insurance plan of $155 per treatment. So that takes $155 off. So we'll say you got $150 less, and now I can get reimbursed 80% of that $150. So I'm going to get 120 of that 300 back. Okay, I'm still going to lose my shirt. So anybody who thinks that this outlier policy is going to anywhere near compensate them for these very, very expensive patients, I think is obviously deluded. Okay, so future adjustments is why the LDOs bought into this. Okay, in order to get everybody on the same page, you have to have a carrot as well as a stick. Okay, so the LDOs were making tons of money on EPO. Okay, and they didn't like the idea of converting EPO from a profit center to a cost center. That was going to cost them. So Medicare said, well, this is the good news. The good news is that you have not had an increase in your composite rate for about 30 years. Okay, and as a result, the $130 that we were paying you in 1980 is now worth $30 in 1980, which is absolutely true. I mean, there was basically no significant increase in the composite rate for inflation or for anything else in 30 years, between 1980 and 2010. So the carrot here was, we're going to build into this bundle payment system an annual adjustment that will allow us to keep pace for inflation. So you're no longer going to be buried by the fact that the dollar is worth less every year that we're giving. Okay, so this will be based on an increase in the ESRD market basket. So if you're a dialysis center, you have to provide what's called a cost report to Medicare every single year that basically outlines all the costs to running your facility. And I mean all the costs. I mean everything that you buy or any service that you use, you keep a ledger, and at the end of the year you submit it to Medicare. And Medicare is that way able to keep track of basically what it costs to run a dialysis unit. And they basically divide all these goods and services into category, and then they track the costs of them, okay? So if the wholesale price of EPO goes up from one year to the next, you will get an adjustment in your bundle payment based on that change. Or if the cost of dialyzers goes up, or the cost of concentrate goes up, or the cost of labor goes up, all those will lead to an increase in the market basket. Now I should also point out that this market basket only takes into account the cost of the item and not the quantity of the item used. Okay, so if you are a very savvy bundler and you decide that because you're going to use more iron, or you're going to give EPO subcutaneously or whatever, that you can save 10 to 20% of your EPO, and every dialysis unit in the country does that. The only thing that will affect the EPO in the market basket is the wholesale price of EPO, not the fact that everybody's using 20% less. Okay, and this was another big attraction, because it means that if I happen to be a dialysis facility that's savvy and more economical and use less of the resource, as long as the cost of the resource doesn't go down, this won't come back to bite me next year, and then you can say, well, you're using less, so we're going to pay you less, okay? The only thing that affects it is the price, okay? So the annual adjustments will also be made to the geographic wage index, and the big news is that in 2014, the ESRD drugs with no IV equivalent, such as phosphate binders and cinacalcet, will also be included in the bundle. Okay, now that's a huge difference, because now you're not only talking about drawing more things into the bundle, you're also talking about oral drugs that require a prescription and a drugstore, okay? So right now, we can give EPO, we can give IV iron, we can give IV vitamin D, and it doesn't really matter in terms of having to work with a dispenser of the drug, because these are IV drugs that we give in the dialysis unit. But phosphate binders and cinacalcet are drugs that patients get at the drugstore, okay? If you're a small dialysis provider, and in 2014, you are now responsible for providing these drugs and paying for them, how are you going to do that? You don't have pharmacists in your dialysis unit. You don't have physicians that are stationed in your dialysis unit that can dispense these drugs. Because the only people who can dispense drugs are physicians and pharmacists. What are you going to do? So this is going to require a whole infrastructure change in order for smaller dialysis facilities who don't have mail order pharmacies, as most don't. Vita and Fresenius do, so they can get around this. But most of the little guys don't. They're doing that. All right, the Quality Incentive Program for 2012, 2 months from now, which I call non-payment for non-performance, because there's no bonus. This is just a penalty. Okay, so to call it payment for performance, I think, is somewhat of a euphemism. It is a 2% withhold with incremental payback for achieving a total performance score of, as you can see, 30. And it's going to be based on the percent of your patients with hemoglobins less than 10, with more being a lower score. That's bad. The percentage of patients with hemoglobins greater than 12, more again being a lower score. That's bad. And the percentage of patients with URRs greater than 65%, with more being a higher score. That's good. Okay. The URR and hemoglobin data are averaged for each patient over the entire year, and for 2012, they're using 2010 data. So your bonus, or penalty, for 2012 has already been determined, actually 10 months ago, when 2010 ended. Okay, so this is pretty much preordained. Each of these measures is worth 10 points. If the provider meets the performance standard, it will receive all 10 points for the measure. If the provider fails to meet the performance standard, it's docked 2 points for each 1% below the standard. Okay, so let's take an example. Medicare has decided that the performance standard for URR greater than 65% is 95% of your patients. So 95% of your patients, when you average your URRs over the entire year, should have an average URR of greater than 65%. If you only have 93% of your patients with an average URR over the entire year of greater than 65%, then you're 2 points below the benchmark, and that's 2 times 2 equals 4 points that get knocked out of the 10 for that particular score. So instead of getting 10 points for that particular indicator, you'll only get 6 points for that particular indicator. Okay? Now, the good news is that the standard can either be the national data from 2008 or your facility's own data from 2007. So the national standard for URR in 2008 was 95% of patients having an average URR of greater than 65%. But your pathetic dialysis facility only had 60% in 2007, getting that URR greater than 65%. If in 2010 you have 61% of patients with an average URR greater than 65%, ding, 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 you get all 10 points. Okay, so it means that you can suck real bad, but as long as you suck less in 2010 than you did in 2007, you get your points. Now, because Medicare was concerned that bundling would lead to an over-withholding of ESAs, because ESAs are the big ticket item, and obviously everybody wants to save as much on ESAs as possible, they were concerned about hemoglobins going too low. So they double weighted the hemoglobin less than 10 at 50% of the weighted total score, and the URR and the hemoglobin greater than 12 at 25% of the total score. So this is your payment. Okay. So total performance score. Oops. Here we go. 26 to 30, you get 0% reduction. 21 to 25, 0.5%. 16 to 21%. 11 to 15, 1.5%, less than 10%. So again, this is out of the bag. This is going to apply in 2012. And as we go towards the end of the presentation, I will show you what's going to happen in 2014. It's much more draconian. Okay, so what would one think would be the predicted consequences of bundling, given all of the things that I already told you? Well, there's going to be less ESA use. Okay, that's the whole point, right? Medicare wants to save on ESAs, and they're afraid that we're giving patients too much ESAs, and they want people to have lower hemoglobins, because the mean hemoglobin of 12 is too high, it's too close to that danger zone from the RCTs, and TREAT even came out after the acquired and grade, and that kind of confirmed that high hemoglobin levels are bad. So there's going to be lower hemoglobin targets. We're probably going to put ceilings on the dose of resistant patients. We're not going to give 400,000 units to a single patient in a month, or 20,000 units, or 30,000 units for treatment. We may go to SC administration and perhaps more IV iron use. We're going to shift to lower cost ESAs if and when they become available, but if you were already using Aranesp and you decided that epoetin is cheaper, you're probably going to go with epoetin. Iron agents, if you were using something very expensive like Veraheme, you're probably going to go to something less expensive like Venofer or Nulicet, which is the generic Furlicet, or you're going to go to generic vitamin D agents, and you were using Hectorol and Zemplar, now you're going to go to generic calcitriol. Okay, these are all the tricks that you might decide to do in order to save money. There may be a shift to more home dialysis modalities. Why? Because home dialysis modalities cost less. Okay, Medicare gives you the same money whether you're dialyzing the patient in center or at home. But when they're at home, assuming they're getting 3 times a week, then you don't have the labor, you don't have the overhead, you're not heating or lighting the patient's home. Okay, and as a result, the cost per treatment is less, and you stand to make more money. And then there will be, we hope, increased efforts to reduce catheter use, because catheters are very expensive, because they increase ESA requirements and they require antibiotics when they get infected. And there was a concern that in our rush to get rid of catheters as much as possible, we might see an uptick in ABG use as opposed to fish use. Okay, we'll see if that happens. Okay, so what data do we have for 2011? Do we have any claims data from Medicare? No. Okay, claims data takes anywhere between 18 and 24 months to see the light of day. Okay, so we don't have that. Do we have ELAB? Does everybody know what ELAB is? ELAB is, it's collected through Network 11, and they actually query all the labs that take care of dialysis patients, and they put together a national profile of what's happening in terms of laboratory data from one year to the next. It's done in the 3rd quarter of each year. Well, we don't have that yet because that's the 4th quarter of every year. So we have nothing from 2012. So what we have is survey data and DOPS data. Okay, and I will go through that for you now. BioTrends is actually an independent company that does surveys of a variety of practitioners, including nephrologists and renal administrators, mostly as marketing analyses for drug companies, okay? And then they sell this information to the drug company. And as it turns out, the CEO of Biotrends is a good friend of mine, and she gives me this stuff for free. Okay, so that's why I can share it to you. Okay, but the stuff that I'm going to show you, if you were a drug company, would cost you $50,000. I'm serious. All right. So in this particular survey, they looked at 230 medical directors, 200 renal administrators. The survey was fielded in mid-2011. This was actually the fourth wave of a previous survey that she had done over several quarters before that, in 2009, as you can see, in 2010. And there's balanced representation from large dialysis organizations, meaning the small independent and hospital-based dialysis organizations, and there was also more quantitative interviews. Okay, so this was the first question. Since January 2011, when the new bundle legislation was implemented, to what degree have your practice patterns shifted as a result? Okay, and the answer is 50% said fairly high, and you can see 20% said moderate, and a few said very slight. But you can see about 3/4 or 2/3 said, yes, this has been a big deal. Okay, we've changed the way we've done business. What is the effect on anemia outcomes? Now, what I'm showing you here is the 4 waves of the study, both for the medical directors and for the renal administrators. And the darkest red represents a negative impact. Okay, so this is the impact of bundling on anemia outcomes. Now remember, the first 3 waves were actually done before bundling started. Okay, and then it was only the 4th wave that was fielded in June 2011, which was after bundling started. And as what you can see here is that there was a fair amount of paranoia that as many as 3/4 of patients were going to suffer in terms of their anemia outcomes before bundling actually kicked in. And you can see that concern has subsided somewhat. I mean, it's not great, it's gone from 71% to 60%, but a lot of this was perhaps fear of the unknown as opposed to what's actually happened in the reality of what they're observing. What about the impact of bundling on overall patient outcomes? I think this is even more interesting. In wave 2, which was done in early 2010, after the proposed rule came out, but before the final rule came out, everybody was freaking out. 71% of MDs said this is going to be a disaster for patients. But after bundling actually came out and was implemented for about half a year, only 40% said this is going to be terrible. So again, the paranoia is the trump the reality. What do you do in the setting of anemia management as a result of bundling? And the circle the one that seems to get the biggest response. Number 1 is use IV iron as a depot sparing strategy. 88% of dialysis providers, represented by their medical directors and their renal administrators, said this is the primary way they're going to decrease equal use, yet maintain hemoglobin range. Second was lower the target hemoglobin range. Okay, and again, this is not only because I want to save on EPO, but because we now have more knowledge, especially from the FDA, who actually did lower the target hemoglobin range in June of 2011, saying you probably shouldn't go much above 10. There's no floor anymore except for the transfusion requirements. And as a result, there's already a secular trend towards lower hemoglobin targets independent of bundling. The other big answer is shift to subQ administration, monitor the hemoglobin more often, increase your ferritin target range, and most of us were using the cont'd target range of 100 to 800, and now all of a sudden we're saying, well, what about that drive study? The drive study says pushing ferritins to 1200 is actually safe and effective in terms of lower EPO requirements. Maybe we should look at that drive study again and actually adopt that, adopt the 1200 as our saving ferritin. A lot of facilities have done that, and increase the TSAT range. And instead of being happy with a TSAT of 20, now I'm not going to be happy until my TSAT is 25 or 30. Cost savings related to secondary hyperparathyroid strategies. Okay, what are we going to do? We're going to use oral vitamin D instead of IV. We're going to switch brands from the brand name Hectorol or Zemplar, or get whatever best deal we can from those vendors. We're going to actually go to a generic calcitriol instead of Hectorol or Zemplar. And we can use more Sensipar, at least until 2014, when Sensipar is not included in the bundle, but vitamin D is included in the bundle as a vitamin D sparing strategy. Okay, the current use of active vitamin D, and again, this goes through the waves. This is the MD hemodialysis and the renal administrator hemodialysis. And again, the question is, how much active vitamin D am I using, how much oral vitamin D am I using, and how much no vitamin D am I using? And as you
go through the waves, you can see the active vitamin D IV is drifting down, the oral is starting to drift up, and the no vitamin D is starting to drift up as well, probably because of Sensipar. Okay, so this is the use of Sensipar. Despite pre-bundle projections that Sensipar would see a sharp uptick in share, the share change has actually not been significant. So even though Sensipar theoretically is vitamin D sparing, and at least till 2014, seems to be a reasonable strategy to decrease dialysis provider costs, it's not actually happening very much. Why? Because there are actually barriers to using Sensipar that we all know. Getting insurance to pay for it perhaps being the biggest one, but the fact that Sensipar makes a lot of patients puke their brains out is probably not insignificant as well. Okay, incidence of parathyroidectomy. Again, this is survey. This is not claims data. We don't know how many parathyroidectomies are actually occurring, but a lot of people think that the incidence of parathyroidectomy is going to go up under bundling. Why? Because parathyroidectomy fixes secondary hyperparathyroidism once and for all, and it doesn't cost the dialysis unit anything, because it's Part A. The patient goes to the hospital, and the dialysis provider doesn't have to worry about it. So if you're a dialysis provider, and you have the choice of giving the patient a very expensive drug or drugs, vitamin D plus or minus Sensipar, ad infinitum, versus sending the patient to a surgeon and cutting their parathyroid gland out once and for all, and then not having to give them much vitamin D at all, what would you pick? Okay, and the answer is pick more parathyroidectomies. And you can see, based on the survey, in both hemodialysis, taking care of the nephrologist, and PD care nephrologist, the projection of patients getting parathyroidectomy is going up. And again, we don't have data to prove this, but this is the sense. Specific cost savings related to patient selection strategies. And again, is there going to be a shift to more hemodialysis modalities? 40% said yes, we think there will be, but as I will show you, it has not really occurred in any great numbers yet. And are there any positive aspects of bundling? Okay, again, this is a survey of both nephrologists and there's actually nephrologists in wave 3 and nephrologists in wave 2. And the biggest answer was more preventative health strategies and CKD, resulting in healthier patients coming to dialysis. Because if I take better care of them when they're CKD, they're not going to be as anemic, they're not going to be as hyperparathyroid, they're going to have fistulas already in place, and all those things are going to save my dialysis unit life. And that's probably true. Reverse cherry picking. This is another big issue in terms of bundling. Are we going to see the expensive patients shunned away from the freestanding dialysis facilities and dumped on the hospital ERs and ultimately into dialysis units? And basically what they're saying is, do we think there's going to be an increase in sicker patients using your hospital-based dialysis facility as a result of bundling? This is asked of nephrologists who are medical directors of hospital-based dialysis facilities, and 70% of them said yes. We're expecting an avalanche of patients because those bastard dialysis facilities out in the community, they're only interested in the bottom line, and they're going to send us those sick patients. Actually hasn't happened yet. Okay, this is the second survey. Invitations just to nephrologists, 1,200 nephrologists to participate. 200 nephrologists are included in the sample frame, 100 completed the renal anemia section, and 100 completed the bone and mineral metabolism section. So general impressions of bundling. Again, the fear seemed to be worse than the reality. If you look at Q1 of 2011, Q2 of 2011, Q3 of 2011, the overall negative impression of bundling has gone down. There's pretty much the same number of neutrals, but the overall positive impression of bundling is actually going up. Pressure from the dialysis unit. Are you feeling pressure as a nephrologist by your dialysis unit to toe the line in certain areas of care in order to decrease overall costs and hopefully get more patients into the reward range of the quality incentive payment? And if you look at Fresenius versus DaVita versus other chain, this is, I think, very interesting data. You can see that Fresenius seems to be the least pressure prone. DaVita is somewhere in the middle, but the little guys are the ones that are putting the most pressure on their nephrologists. Why? Because the little guys don't have the economies of scale. They're operating at much smaller margins, so every penny they can save is going to be more important than it is to a DaVita or Fresenius that have hundreds of thousands of patients across which they can spread their costs. Okay, so what do you think the bundling impact is going to be on ESA and iron usage to date? And as you can see, these darker bars are increase in iron usage anywhere between 10, 20, and greater than 20%. Most in the 1 to 10% range increase in total iron dose per month. And then the red bars are decreased EPO dosing, and you can see that most of them are saying that we're decreasing our EPO dose between 11 and 20%. And interestingly enough, this is very similar to what was experienced in Japan when they went to a bundle payment system in 2006. When Japan did pretty much the same thing that we did in the United States, they went from a fee-for-service for these injectables to a bundle payment system, they found that their iron use went up by about 10 or 11%, and their EPO use went down by about 15 to 20%, almost the exact same thing. Okay, distribution of hemoglobin levels in dialysis patients between quarter 2 and quarter 3. So this is the second quarter of this year, this is the third quarter of this year, and as you can see, we're seeing an uptick in the percentage of patients less than 10. Okay, now again, that may be because of secular trends in the FDA scaring the bejesus out of everybody that EPO is toxic and is going to kill people, but as a result, we're seeing less EPO used and less hemoglobin levels achieved. This is the distribution of hemoglobin testing frequency, okay? And one of the lessons that has been learned over years of experience is that the more often you check your hemoglobin level, the more you can use those frequent determinations to trend as opposed to acting on a single level per month. And the trending is much more predictive of the appropriate dose change than using a single value. And so as you can see, almost all the large dialysis organizations are going to twice monthly testing. We have 56%, Fresenius 44%. It hasn't penetrated the small dialysis units as much. But again, this seems to be becoming the standard here. Twice monthly as opposed to single hemoglobin testing. Now, we all predicted that sub-Q administration would become more popular as a dose-sparing strategy. And again, if you look at the quarters as they go along, third of 2010, fourth, and then 11, you can see the percentage of nephrologists who have any patients on subcutaneous EPO has gone from 10% to 31%. And if you look among those nephrologists who said they have patients on subcutaneous EPO, you can see most of them are small percentages, okay? But nonetheless, we are seeing an increasing number of nephrologists saying that they have patients. Okay, IV iron protocol changes. Again, what we're seeing is increased use of iron or more iron and changes in iron to the higher level. Blood transfusions. As you move that hemoglobin distribution curve to the left, you're going to get more and more patients under whatever transfusion threshold you happen to use, and as a result, we're going to see more transfusions, and indeed, with the continuous uptick in the percentage of patients that the nephrologists say they have. Okay, use of nutritional vitamin D. This is the oral vitamin D, calciferol or cholecalciferol that you give for patients who have low 25-hydroxy vitamin D levels. Why do we do this? Well, one, because Kate Vigo said we should, and number two, that we hope that maybe some of that nutritional vitamin D will be converted to active vitamin D, and that will be cost-sparing in our dialysis unit, because that will suppress PTH. And we will have to use less calcitriol or Zemplar or Hectorol, whatever, to get the PTH to whatever target range we have to use. And as you can see, when you look at the hemodialysis patients and the peritoneal patients, there's been a continuous uptick in the percentage of patients receiving nutritional vitamin D, which is not in the bundle. Patients have to pay for this themselves. Okay, the use of active vitamin D, conversely, is going down, because that's the whole point. We want to use less of the drugs that cost us money in the bundle payment environment. So whether you're looking at PD, hemo, stage 4 CKD, or stage 3 CKD, less so in the CKD patients, but certainly very perceptible in the ESRD patients, there's less active vitamin D being used. Now, what about market share by dialysis chain? Okay, if you're a dialysis chain, especially a big dialysis chain, you have leverage to get good prices, and you're basically going to sell out to the lowest bidder. So there's been a scramble over the last 12 months of the vendors, Abbott and Genzyme and everybody else in the vitamin D market to offer the best deal to dialysis facilities, and as a result, we're seeing trades. Okay, and as you can see here, there was a significant shift away from Zemplar, and in some cases towards Hectorol, because apparently Abbott, Genzyme was more aggressive in marketing their Hectorol, probably on price. If you look at Zemplar, went down by 39% in quote other chains, went down by 33% in DaVita, and that was pretty much reflected by a reciprocal rise in Hectorol. But on the other hand, FMC looks like it moved from Hectorol to Zempic. Is that what you guys did here? Use of Sensipar over time. Again, the prediction was that Sensipar, until 2014, when it is included in the bundle, will be a vitamin D sparing strategy. And as you can see, this is based on survey. This is not based on actual use. There is a perception on the part of nephrologists that Sensipar use has increased from 34% to almost 40% in hemodialysis patients. Not true. I will show you data that shows that's a way overestimation. You may prescribe the Sensipar, but in many patients, the patients don't actually take it because they can't afford it, the insurance company denies it, or they start puking. Okay? All right. Now, if the use of Sensipar was not limited by cost and reimbursement, which is a big barrier, 90 milligrams of Sensipar a day costs $1,000. And if the patient has a typical copay of 20%, that's $200 per month per patient. Most patients won't pay that. Okay, and as a result, they don't get their Sensipar. So in the best of all possible worlds, if Sensipar was free for everybody, that the ferry came down and just handed it out, how much Sensipar would you use? The answer is we give it to about 50% of our patients. Okay, now the Quality Incentive Program. How do you feel about the Quality Incentive Program? What is the act of the Quality Incentive Program on your anemia management programs? Pretty neutral. Okay, what is the impact of the 2% penalty? It's kind of split between neutral and somewhat of an incentive. Now again, these are nephrologists. The incentive probably only comes to them via their medical directorship if there's some kind of clause in the medical directorship that better performance and a reward by CMS somehow leads to a bonus in your medical director's salary. If you're a regular old nephrologist and all you're collecting is the monthly capitation rate, then the quality incentive payment is probably not going to affect you directly. But again, there is somewhat of a positive incentive. Okay, this is DOPS. This is another source of data. Everybody familiar with DOPS? Okay, so this is the Dialysis Outcomes and Practice Pattern Study. It's run out of the University of Michigan. It's actually an international study that looks at the United States, Canada, a number of countries in Western Europe, Australia, New Zealand, and Japan. And it takes snapshots of processes and outcomes and allows us in individual countries to compare our performance not only with ourselves, but also with the rest of the world. And for the United States, this is a wake-up call because we suck compared to the rest of the world. But I will just show you United States data over time from before bundling versus after bundling. This is what we have. Now, source of the DOPS data for the United States is what's called a stratified random sample, 145 U.S. facilities, which are picked because they're representative nationally by facility type, organization size, or over freestanding hospital base, and achieving coverage to the CMS sample time frame at average values and tails of distributions of key measure, blah, blah, blah. So basically what they did is they picked dialysis units that represent kind of a sample of what's going on in the whole country, and then they use that to extrapolate what's happening in the whole country. But you have to remember this is a sample. All right. So this is hemoglobin. All right. Now we all expected that due to the combination of constraints on ESA use, because it costs us money, as well as the FDA's demonizing of ESAs in its June 2011 pronouncement, that we would see a substantial drop in ESA use and probably as a consequence, a substantial decline in hemoglobin levels. Not. Okay, so you can see that there's been a slight drift at the lower hemoglobin range. Here, this is 10 to 10.9. This is 9 to 10. You can see most of the patients still remain in the 11 to 11.9 range. This is August 2010. This is April 2011. This is the latest data we have from DOPS. There's a slight decrease at the upper end of 12 to 12.9. Interestingly enough, over 13 has not changed to any significant degree. So if anybody thought there was going to be a dramatic cliff over which EPO plummeted, or EPO use plummeted, hemoglobin levels plummeted as a result of bundling, that clearly has not occurred. This is the weekly IV EPO dose prescribed, 1 month average. And as you can see, then a slight decrease in the lower level of 1 to 10,000 units, which would be an average of about 3,000 units per treatment. The number of the patients in the middle, between 10,000 and 25,000, has gone up slightly. But interestingly enough, the percentage of patients at the highest levels, 25,000 units per week, or about 8,000 units per treatment, does not really change. So nobody seems to have gotten the memo
that using tons of EPO probably doesn't matter, and you probably shouldn't do that, and it's probably what caused the bad outcomes in Treat and Choir and National Hematocrit Study. But again, at the lower level, there seems to be some change. All right, iron use. This is probably the most dramatic. Okay, everybody got the memo about using more iron to spare EPO. And you can see the percentage of patients receiving IV iron during the past month increased from 57% in August 2010 to 78% in April 2011. This is probably the single most dramatic change in processes that we've seen as a result of bundling. Serum calcium, pretty much nothing. Serum phosphorus, pretty much nothing. So if we were concerned that the shift towards the generic calcitriol, which is a vitamin D3 agent, versus the Gemplar and the Hectorol, which are vitamin D2 agents, was going to cause a epidemic of hypercalcemia. Because as we all know, vitamin D3 agents cause more calcium absorption from the gut than vitamin D2 agents. That has not occurred. Or if it has occurred, people are adapting to it by lowering the calcium in their dialysate or shifting from calcium-containing binders to non-calcium-containing binders. But I don't think everybody is smart enough to have done all that to completely mask any change in calcium phosphorus. I think we just haven't seen the dramatic shift towards generic calcitriol that we expect. Here's parathyroid hormone. This is big. They're going up. No question about it. Okay, because people are backing off on vitamin D, whether it's generic or Gemplar or Hectorol, and then cost containment output. And they're changing their target range. Okay, everybody was using the KDOPI recommendations of 150 to 300. Now they're using the KDIGO recommendations of 100 and maybe 500. They're saying this is IV vitamin D use. Really hasn't gone down. In fact, it's actually gone up a little bit. So maybe the doses are going down, but again, this is the percentage of patients who received any form of IV vitamin D. And if anything, it's gone up. It certainly hasn't gone down. And then cinacalcet use. Remember, 40% thought, 40% of nephrologists thought the patients were getting it, 50% thought their patients deserved it, and 20% are actually taking it based on claims data through DOPS. Okay. This is vascular access trends. Okay. Remember, I raised the concern that in a rush to get rid of catheters and avoid higher EPO doses and antibiotics and thrombolytics and all the other things that catheters require, there would be an uptick in graft use. Hasn't happened. Okay, and these are data through July of 2011. So it's going to occur, hasn't occurred yet. Now, how do the patients feel about this? Okay, this is a survey I did of 2 networks. These are the networks that I happen to be affiliated with, networks 9 and 10, Ohio, Indiana, Kentucky, and Illinois. And if you look here, is there a rash of complaints by either dialysis providers that they're getting screwed under bundling, or patients that they're getting screwed under bundling? No, not in network 10, not in network 9. This is the trends in involuntary discharge rates. Now, the conditions of coverage require you, as a dialysis provider, if you're going to involuntarily discharge the patient, to inform your ESRD network. Okay, and these are the network data that I got from network 11, very kindly from them. And since it was only through September of 2011, we compared it to January through September of the previous 4 years. And you can see, if anything, the involuntary discharge rate has actually gone down over the last 5 years, and there's been no uptick as a result of bundling. What about effective bundling on modality? Okay, we thought that maybe because home dialysis modalities are cheaper for the provider, no overhead, no labor, that there would be a big shift towards home dialysis modalities. Well, it's small. Okay, this is Network News, Nephrology News and Issues, survey of the top 10 dialysis providers. I just took this out of the July issue. In May 2011, among those top 10 dialysis providers, there was 8.2% PV and 7.4 as compared to 2010. Very, very small change. And again, when I looked at my own networks, 10.4 versus 9.9. So small, but certainly not significant. Now, let's move to the future. What's going to happen in 2013? In 2013, it's going to be based on 2011 data, which is already almost over. This is still going to be claims data. Okay, every time you submit a claim for dialysis for your patient for the previous month, you have to put their hemoglobin level on if they receive EPO, and you have to put their URR on, and this is where the source of the data is. Okay, now this I already showed you. This is the penalty scale for 2012. In 2013, the hemoglobin less than 10 indicator is being dropped because
because the FDA no longer supports a floor for hemoglobin. So it's only going to be those two, but the penalties are going to be much bigger. You only have 0 penalty if you get 30 points. Anything less than 30 points, you lose, okay? This 0.5% penalty range has been completely eliminated. So you drop from 0% penalty all the way to 1% penalty, even if you got dinged only 4 points. If you got dinged 5 to 10 points, you lose 1.5%. And if you got dinged more than 10 points, you lose all 2%. So the grading on the curve has gotten much tougher. In 2014, we are hoping, or at least CMS is hoping, that this will no longer be based on claims, it will be based on data that is collected through Crown Web. Raise your hand if you've heard of Crown Web. Okay, Crown Web is like Skynet was in Terminator. Beware. Okay, well first of all, it's not finished yet. Medicare is saying it's going to roll out in February of 2012, and nobody anywhere, CMS or otherwise, really thinks that's going to happen because there's still too many bugs. But when it does eventually roll out, all data collection will be electronic in real time and will not require claims anymore. So Fresenius and DaVita are going to take their huge computers and somehow marry into the CMS computers and dump all this data, and the CMS is going to sort it out and decide whether or not you're a winner or a loser in the quality incentive payment. So there's going to be 5 clinical measures that'll be 90% of your score, and they'll continue the hemoglobin greater than 12. They're going to shift from URR to KT over V only about 15 years after the rest of the world. They're going to look at vascular access, in particular catheters and AV fistulas. They're going to look at your vascular access infection rate, and they're going to look at your standardized hospitalization ratio. And each of these is going to be count equally out of the 90%, so 90 divided by 5 is 18 points apiece. And then there's going to be 3 reporting measures that are 10% of your scores, that are basically attestations into Crown Web that you did these things. Okay, so you're on your honor that you actually did them if you say you did them, but God forbid somebody actually comes in and audits you and you say you did it and you didn't. That's fraud and you go to jail. So, reporting infections to the National Health Safety Network, patient's experience of care, which is the in-center hemodialysis CAPS, instrument that you have to administer to every patient on an annual basis, and mineral metabolism, which is measuring your calcium and phosphorus monthly. Who doesn't do that? That's a freebie. Okay? So, summary and conclusions, bundling was much more threatening in theory than in reality. It's induced facilities to provide more cost-effective, which I think is smarter care. Patient outcomes have not been compromised so far. There's been no epidemic of cherry picking. And I don't think things are going to change much until 2014 when the oral meds are included and overall Medicare cuts may kick in, which will lead to a rebasing of costs. So what I told you about the current legislation being based on the market basket that includes only the cost of the item and not how much of the item you use, Medicare can change the rules. And in the current economic climate where the federal government is trying to save every penny they can, they're going to say, look, we're paying dialysis units for the amount of EPO they used in 2008, in 2011, when everybody agrees they're using 15 or 20% less. Why are we doing that? Why are we giving the dialysis unit a windfall? That money could be better spent somewhere else, and watch out because there may very well be new legislation that changes the rules all over again. That's it for me.